My name is Rachel Greenup, and I'm one of the breast surgeons in the Duke Department of Surgery Breast Cancer Program within the Duke Cancer Institute. Today we will be reviewing breast cancer in young women, unique issues during and after treatment. We will cover several topics, starting with a case presentation which will highlight many of the challenges in diagnosis and treatment of our young breast cancer patients. We will then review surgical treatment options, issues around systemic therapy, fertility preservation, and survivorship care, and we will finish by reviewing the resources available to both Duke patients, practitioners, and their families at the Duke Cancer Institute Breast Cancer Program. So our patient is a 37-year-old female who finds a right breast mass and brings it to the attention of her primary care doctor. And you can see on the left side of the screen, her right mammogram demonstrates a spiculated mass as highlighted in the circled area. She goes on to have an ultrasound, which is also suspicious for a cancer, and a core biopsy reveals an invasive ductal cancer, which is estrogen receptor negative, progesterone receptor negative, and HER2 positive. This is a triple negative breast cancer. So now what? She is scheduled in our multidisciplinary breast cancer program, and there she will meet her breast cancer surgeon, the medical oncologist, and the radiation oncologist, including the plastic surgery team, the nutrition team, and the genetic counselors if appropriate. And during that initial meeting, the team will consider multiple issues, including the incidence and disease and prognosis of this disease, what the best option for surgical treatment of her breast cancer is, whether she will need chemotherapy, and recommendations for genetic testing and counseling, including fertility preservation and psychosocial ramifications of her diagnosis. We will start with a basic understanding of how common this disease is in young women. Breast cancer is the #1 cancer diagnosis among women of all age groups in the United States, and it affects 1 in 8 women in this country during their lifetime, and it is the #2 cause of cancer-related death. This graph demonstrates the trends in age-adjusted cancer death rates among women in the U.S., with over 200,000 women being diagnosed every year and an estimated 40,000 women dying every year from this disease. Though 1 in 8 women will develop breast cancer by age 80, less than 10% of breast cancer diagnoses occur before age 40, with the majority occurring between ages 35 and 40 years of age. Incidence rates appear to be stable over the past several decades in young women in the Western world, and that being said, survival rates among young women are lower than for their older counterparts, which may be related to the stage of diagnosis or the type of cancer most commonly seen in this population. When we break age groups down further, the incidence of breast cancer in women less than or equal to 20 is 0.1%, in women 20 to 34 is less than 2%, and in women ages 35 to 44 is approximately 10.5%. Despite being a rare diagnosis in this population, breast cancer remains the most common cause of cancer-related death among women 40 years and younger. This data was published in 1994 in the Journal of Clinical Oncology, and for the first time demonstrated that younger patients had poorer prognosis with a greater risk of recurrence, higher risk of metastatic disease, and poorer outcome overall. As improvements in chemotherapy continue, we will hope to see improvements in overall clinical outcomes. This next data was published in the Journal of Clinical Oncology in 2008 through the collaboration of our Duke Cancer Program and the UNC Medical Oncology Group, which evaluated tissue from 784 breast cancers in women less than or equal to 45 and compared them to tissue among women greater than or equal to 65. Breast cancer in younger women had lower rates of hormone receptor positivity, higher rates of HER2/neu positivity, larger tumor size, and higher grades. Tumor properties correlated with disease-free and overall survival, and when tumor biology was adjusted for, age at diagnosis was the strongest predictive factor in survival, with younger patients having poorer survival when compared to their older counterparts. When we meet with our young breast cancer patient, we will start by reviewing surgical treatment options for her. And these include breast conservation, mastectomy, contralateral prophylactic mastectomy, and if necessary, options for reconstruction. The term breast conservation means lumpectomy and radiation, and this implies that the cancer is removed with a margin of normal tissue surrounding the tumor, with the remaining breast receiving radiation therapy. Because the majority of breast cancers cannot be clearly defined by the hands of surgeons, we rely on radiology to localize the tumor within the breast. This was traditionally done with the placement of a Copans wire, which is a thin, flexible wire that marks the clip in the tumor the day before surgery. During surgery, the wire is followed down to the cancer and the cancer is removed with the wire. And here you can see the specimen is imaged in the operating room to verify that the tumor, the wire, and the clip have been removed. More recently, our group at Duke has added a seed localization program as an option for patients undergoing lumpectomy. The radioactive seed is a radioactive marker seen here on the slide that is placed at the site of the cancer, and using a gamma probe at the time of surgery, the cancer is localized within the breast. Research to this point suggests that seed localization not only improves comfort for patients, but decreases the need for second surgery through improved margins and results in smaller volumes within the resected tissue. Many women are not candidates for breast conservation, or they choose mastectomy. This implies removal of all the breast tissue with or without reconstruction. The term modified radical mastectomy implies removal of the breast tissue and ipsilateral axillary lymph nodes. In the current era, many women have the option of breast reconstruction following mastectomy, either with an implant-based reconstruction or use of their own tissue. This patient underwent a nipple-sparing mastectomy through an inframammary incision with an implant-based reconstruction, and we routinely offer this to appropriate patients at Duke. The breast can also be reconstructed using muscle or tissue from the abdomen as a free flap, which is an excellent option for many of our patients and also offered by our plastic surgeons. Historically, women with breast cancer were offered only mastectomy until data from the NSABP-B6 trial, which was published in 1985, demonstrated that a woman undergoing lumpectomy followed by radiation had equivalent survival to women undergoing mastectomy. This data was more recently confirmed by research performed here at Duke by Dr. Shelley Wong through evaluation of over 100,000 women in the California Tumor Registry, identified between 1994 and 2004 with stage 1 to 3 breast cancers. The blue line on the slide represents women undergoing breast-conserving surgery with radiation, while the red line represents women undergoing mastectomy. Results from this study found that there was a slightly higher improved disease-free and overall survival among women undergoing breast conservation, with the greatest benefit seen among women over 50 with hormone receptor positive cancers. Many patients, especially younger breast cancer patients, are interested in discussing contralateral prophylactic mastectomy. We know that rates of bilateral mastectomy are increasing across the United States, with the highest increase among younger women. We additionally know there is no survival benefit, meaning that among average risk women, they live just as long if they only treat their affected breast and leave their opposite breast in place. That being said, many women choose contralateral mastectomy for improved symmetry, peace of mind, and reduced imaging surveillance. This is a complex decision that patients should discuss with their doctors in making an informed decision. Evaluation of the lymph nodes is also an important component of surgical therapy for breast cancer. Patients undergo injection of their breast before surgery, and during surgery, a sample of lymph nodes are identified with a gamma probe to be removed and evaluated by the pathologist. Our patient will also meet with medical oncology during her initial consultation, and this is to discuss the need for chemotherapy and/or endocrine therapy. The stage at diagnosis correlates with prognosis and is determined by the size of the tumor and the number of involved lymph nodes as seen on the final surgical pathology. Fortunately, the vast majority of breast cancers in the United States are diagnosed in early stages, with only 5% of women found to have metastatic disease at the time of diagnosis. Many factors contribute to the decision to pursue chemotherapy in young breast cancer patients, and this is driven by their risk of distant recurrence. These include axillary nodal status, tumor size, tumor phenotype if they're triple negative, HER2 positive, or have a high Oncotype DX score, lymphovascular invasion, patient age, and histologic grade. Occasionally, there is a benefit to giving chemotherapy prior to surgical removal of the cancer. Preoperative chemotherapy is referred to as neoadjuvant chemotherapy and is indicated for the following cases: locally advanced cancers, large primary tumors, fixed or matted axillary nodes, an attempt at breast conservation, or a need to assess response to treatment. In the NSABP B18 and 27 trials, women were randomly assigned to preoperative versus postoperative chemotherapy, and this study most importantly demonstrated that there was no survival difference due to sequence of treatment. Preoperative or neoadjuvant chemotherapy has several benefits, including similar rates of in-breast recurrence, increased eligibility for breast conservation, decreased volumes of resected tissue, similar re-excision rates, decrease in mastectomy rates, and no difference in surgical complications, with the ability to assess the in vivo response to treatment. Young women are also more likely to have unfavorable tumor biology, including higher frequency of triple-negative breast cancers, higher rates of cell division, greater rates of lymphovascular invasion, and a greater percentage of grade 3 tumors. These features in turn make them more likely to respond to neoadjuvant chemotherapy. We will also think about genetic counseling and testing in this young breast cancer patient, and it's critical in determining appropriate treatment recommendations and lifelong surveillance. This table includes the updated NCCN guidelines for consideration of genetic testing for BRCA1 and 2 mutations. Though they are publicly available on the NCCN website, any woman less than or equal to 45 should be referred for genetic counseling and potential testing. Historically, we looked for BRCA1 and 2 mutations primarily among women of Ashkenazi Jewish descent. Though we know that in this population the prevalence of this mutation is high, we have more recently learned that women of other races and ethnicities remain at risk for harboring hereditary cancer mutations. Age at diagnosis impacts prevalence, with women less than 40 years of age having a risk of up to 40%. We know that race and ethnicity impacts prevalence, and among high-risk women, the risk of BRCA1 and 2 mutations approximates 15%. Recently, our group here at Duke demonstrated a prevalence of BRCA mutations up to 30% in women with triple-negative breast cancer. BRCA1 and 2 mutations are also associated with a higher lifetime risk of developing other cancers, and these include breast in the female patient, ovarian, male breast, prostate, pancreatic, melanoma, and gastric cancers. The purpose of identifying a mutation is not only to make decisions about an active cancer, but also to improve surveillance and consider prophylactic surgery. Female patients who are not affected by an active cancer can consider prophylactic mastectomy, screening for ovarian cancer, and chemo prevention. Male carriers should undergo mammographic surveillance, and all carriers can consider melanoma and pancreatic cancer surveillance. Though many women with a known BRCA1 or 2 mutation will elect for bilateral mastectomies, breast conservation for treatment of a known cancer with good surveillance after treatment remains a very viable option. This data from Lori Pierce demonstrated that though the risk of in-breast recurrence and development of a contralateral breast cancer are higher in this population than in average-risk women, including rates of a recurrence of about 25% and a risk of a contralateral cancer of about 40%, there is no difference in survival between women treated with breast conservation versus mastectomy. In our young breast cancer patients, we will also address their desire for fertility preservation. Young women are often diagnosed with breast cancer at a stage in their lives when fertility issues and family planning are of utmost importance, and the majority of women under 40 receive systemic chemotherapy, which affects their ovarian reserve, their future fertility, and can hasten early menopause in many of these patients. In a retrospective survey of young breast cancer patients with a mean age at diagnosis of 33 years old, over half of women recalled substantial concern of treatment-related infertility at the time of their breast cancer diagnosis. This was significantly related to their wish for children, number of prior pregnancies, and past history of difficulty conceiving. Almost a third of these women reported that fertility issues impacted their cancer treatment decisions, but never discussed this with their cancer team. And interestingly, more of these young women recalled discussing treatment-related menopause with their providers than addressing fertility issues. About half reported their fertility-related concerns were adequately addressed. A major side effect of breast cancer treatment in these young women is chemotherapy-induced amenorrhea. And this is when women stop having regular periods and stop ovulating after their cancer treatment. Young women are more likely to receive systemic chemotherapy during their breast cancer treatment due to their young age, more aggressive disease, tumor subtype, and often late presentation. Chemotherapy-induced amenorrhea is age-related and therapy-related, and interestingly, younger breast cancer patients are less likely to experience chemotherapy-induced amenorrhea and more likely to regain their ovulatory cycles after treatment. When young women experience sensation of menses due to treatment, it tends to occur for a shorter time. This table describes the incidence of chemotherapy-induced amenorrhea, which increases with the age of the breast cancer patient and may actually provide a benefit to the patient from a cancer outcome. There are many options for fertility preservation for our young patients, and these include oocyte and embryo cryopreservation and ovarian preservation, which have been described. Pregnancy after breast cancer treatment actually has no impact on recurrence. Treatment has no harm to future pregnancies, and the safe timing of pregnancy after diagnosis remains unknown, though most recommendations are for 2 years following completion of treatment, during the period when a woman is most likely to unfortunately have a recurrence. The American Society of Clinical Oncology has developed recommendations on fertility preservation and points of discussion for young patients. ASCO recommends that providers review the following discussion points with patients and their partners, including the threat to fertility being based on the treatment, that fertility preservation not delay cancer therapy, that there is no risk of disease recurrence with fertility preservation methods, and that there are no risk of treatments to future pregnancies. But early referral to fertility specialists improves success and should be considered at the time of the initial consultation, with guidance from the oncology team. The final and critically important aspect of treatment for our young patients is quality survivorship care. Young breast cancer survivors share many of the same issues that older women face following breast cancer diagnosis and treatment. However, certain issues remain unique to this young subgroup. Survivorship issues unique to young women include treatment effects such as amenorrhea, early menopause, osteoporosis, secondary cancers, fertility preservation, unique psychosocial concerns, and lifelong surveillance. This is the very long list of potential late side effects of breast cancer treatment, with each step of the treatment process having its own set of associated complications. As you can see here, issues such as lymphedema, ovarian failure and early menopause, development of secondary cancers, cardiac toxicity, and osteoporosis are very uncommon in healthy premenopausal women, but breast cancer diagnosis and treatment add a layer of complexity to the health and quality of life for our young breast cancer patients. There is significant data across many studies that young women unfortunately experience a substantial amount of psychosocial distress associated with their diagnosis that lasts for several years. Survey data finds that a breast cancer diagnosis has a higher impact on the lifestyle and careers of young women when compared to older breast cancer survivors. Younger age is also predictive of higher distress at 1 year. Treatment-related menopause is also in this population and correlates with higher distress, and approximately 10% of young women report being denied health or life insurance after diagnosis of their cancer. 18.2% of patients identified work-related problems, and significant changes in sexual function occur more commonly in young women and seem to have a greater effect on their overall quality of life. All of these issues need to be addressed by the healthcare team, and we have resources and support services for our patients to do this. The cornerstone of breast cancer follow-up is history, physical exam, and imaging mammography. 75% of recurrences present with patient complaints of symptoms or changes in physical exam. These findings should be investigated thoroughly in breast cancer survivors with routine follow-up and annual imaging. Recurrences in our young patients can occur within the first 5 years after treatment or can occur throughout their lifetime and depends on the tumor subtype. Breast cancer survivors should be educated about signs and symptoms of recurrences, including chest wall changes, skin changes of the breast, including nodules, rashes or erythema, redness of the overlying skin, or any swelling of the lymph nodes. Risk of a new primary on the opposite breast ranges from 0.5% to 1% per year, which increases with women under 35 having a long life ahead of them. The American Society of Clinical Oncology has encouraged cancer providers to complete a survivorship care plan, including treatment toxicities experienced by the patient specific to their treatment plan, including anticipated long-term issues. Long-term follow-up of breast cancer survivors is very complex and should include several important goals of care: evaluation for early and post-treatment effects, evaluation for ongoing psychosocial burden, promotion of health and well-being, and coordination of care with other providers. In caring for these patients, it remains important that non-cancer related issues are not forgotten and that promotion of overall health and well-being remains a focus. Prevention of non-cancer related morbidity and mortality and routine health maintenance is especially important in these very young women. Our Duke Breast Cancer Program has much to offer patients and their families, including top-notch breast imaging, a multidisciplinary team, expertise in unique populations, including young women, as we discussed today, elderly patients, inflammatory breast cancer, high-risk patients. We have ongoing national clinical trials, cutting-edge surgical and radiation techniques, daily access to physical therapy, psychosocial support programs, a sexual health program, and our survivorship clinic. This is our team at the Duke Breast Cancer Program within the Department of Surgery. And these are resources for our breast cancer survivors. Thank you very much for your time today.